Hello, everyone, and welcome to our Essential Tremor Virtual Education Conference, or forum, actually. My name is Patrick McCartney. I'm the Executive Director of the International Essential Tremor Foundation. Today, we're going to be hearing from Dr. Britt Stone, who will be discussing DBS programming and specifically image-guided programming. But before we get started, I'd like to thank our corporate partners, Medtronic, Abbott, Insightec, Sage Therapeutics, Jazz Pharmaceuticals, Cala Health, Boston Scientific, Praxis Precision Medicines, and Allevion. All these companies allow us to provide these webinars, our podcast series, and hopefully sometime here in the near future, our in-person ET education forums. Now I'd like to introduce our speaker. Dr. Britt Stone is an assistant clinical professor of neurology in the Division of Movement Disorders at Vanderbilt University Medical Center. Dr. Stone completed her Bachelor of Science degree at Vanderbilt University, medical degree from Meharry Medical College, and completed her neurology residency and movement disorders fellowship at the Hospital of the University of Pennsylvania and New York University Langone Medical Center. Her personal interests include travel, language learning, reading for pleasure, and music. So welcome, Dr. Stone. We thank you for joining us today, and I'm going to allow you to share your screen so you can get into your presentation.
Thank you so much. Let me get my screen shared here. There we are. So, as we have this load beautifully, we're going to talk a bit about essential tremor, which, of course, I'm sure anyone who is listening is familiar with. And then we're going to kind of delve into the world of deep brain stimulation and the benefits of image-guided programming. So my disclosure is that I am, as you can see, a Boston Scientific consultant. And so where we're going to be going in this talk, first, an essential tremor review, treatment options, deep brain stimulation with Boston Scientific, and where to go to learn more. So just to kind of recap about essential tremor, which is a very common movement disorder. This is a neurological disorder that impacts about 40 million people worldwide, and for the United States, about 10 million Americans. Usually the age range that people present is between the ages of 40 to 50 years of age. But honestly, I have seen people as young as in their late teens and the elderly as well. So I think a thing that's really important is to think about essential tremor as a tremor of essential activity. So that's really kind of riding and getting dressed and using your hands for fine motor skills and eating and holding beverages and things of that nature. So some symptoms of essential tremor are, as I stated before, a tremor that impacts your ability to do your activities of daily living. It can affect most usually the upper extremities, so the hands, the head and neck, and even the voice. In addition, there are some non-motor symptoms that can also be associated with essential tremor. People can notice some mild cognitive changes, maybe some difficulty with short-term recall or language fluency, also some imbalance with their walking, feeling a little unsteady on their feet, and even some depression and anxiety. So often when people come to the movement disorder specialist or a neurologist in general for their tremor, they're often concerned about, do I have Parkinson's disease first? Because that's often the first thing people think about. We have a nice little schematic here of just kind of some general ideas that help us think about Parkinson's disease versus essential tremor. Of course, in medicine, nothing is 100% because humans like to defy categorization. But for the most part, essential tremor is a tremor of action. Parkinson's is a tremor of rest. Essential tremor is a little faster. Parkinson's is a little slower. Essential tremor happens a little bit younger. Parkinson's a little older. Family history, maybe more in essential tremor, not necessarily in Parkinson's. And alcohol can often improve essential tremor. So I'll often ask patients, have you noticed if you have a glass of wine or a cocktail that your tremor seems to be better? And often people kind of even medicate with this before they even make it to the doctor. In addition, there are targets of the deep brain stimulation electrodes, and that is determined based on your Parkinson's disease versus your essential tremor. So options for treating essential tremor before we head to the deep brain stimulation surgery. Usually people first, and we go from, the category of least invasive to most invasive. Usually medication is the first thing if people are bothered enough by their tremor. So there are a host of different medications. I think it's interesting to note that there are no specific medications for essential tremor specifically, but rather we use medications that are used in other conditions, blood pressure management, seizure disorder, and we use those medicines to actually treat tremor. And unfortunately, for some people, the limiting benefit of those meds are other systemic side effects like cognitive slowing or dizziness or nausea or slowed heart rate or fatigue that keep people from being able to be at higher doses of these medications, or that the medications can interfere with other necessary meds that patients can be on. If people have tremor in their neck or in their voice, and sometimes in the hand, botulinum toxin injections are another treatment for kind of focal tremor. Also, we send people for physical or occupational therapy. The occupational therapists have hand therapy, which can often be helpful with helping people with daily living activities. I encourage some patients to use weighted utensils or wrist weights around the wrist when they're going to do specific things with their hands, if they notice that when they have something heavier in their hand, that their tremor seems to be better. There also are surgeries called ablative surgeries, which are really kind of a more sophisticated version of the lesion surgeries of the past, where you make a permanent kind of lesion or scar in a region of the brain that then will decrease tremor. And then there is, of course, the subject of this hour, deep brain stimulation, where we use a battery-powered device that uses electricity that we modulate to actually block signaling in the brain to control movement. So what is deep brain stimulation? So as you see here, it's a neurosurgical procedure that can help manage essential tremor and other neurological disorders as well, when they're not optimized by medication. And what's done is it's kind of a two-part surgery. There is and I'll use my cursor here, an electrode that's placed in a certain region of the brain, which in the setting of essential tremor is a nucleus in an area called the thalamus, called the VIM. And then there is a pacemaker, sort of like battery, that's placed in the chest wall, and it can either be rechargeable or non-rechargeable. And here are a picture of our leads. And so this is kind of your system for deep brain stimulation surgery. And in essential tremor, typically it'll be one side where this lead is connected to the battery. So kind of debunking some myths. I think some things to keep in mind is that deep brain stimulation is not experimental. We are no longer guinea pigs. We know that this is a tried and true treatment for essential tremor that is resistant to medication. It's FDA approved. It's not a last resort treatment. The goal is to improve quality of life in patients, and there's no time like the present for that. And we've treated over more than 200,000 patients with essential tremor with DBS. We have seen that with DBS, we have been able to improve tremor by 60 to 90%, which is really priceless when you think about the quality of life and the improvement of just general daily living activities that patients are now able to have because of the surgery. And 98% of patients who receive DBS therapy would recommend it to others. And I have to say, this is often how I get new patients, is because a patient has had the surgery and then they've told their neighbors or people at their church or people in their community about this. So some further myths we want to debunk. So we talked about the fact that this is not an experimental therapy. We also want to debunk the fact that it's only effective in the short term. I think something that is important to keep in mind is that there can be long-term satisfaction and years of being able to program DBS effectively to help with symptom management. And actually, image-guided programming affords a lot of that ability, which we'll talk about in a little bit. Also, there's this idea that DBS is a highly invasive or permanent procedure. And actually, in the general kind of theme of neurosurgical procedures, it is minimally invasive and it's reversible. You can remove the leads if you need to. You can also take out the battery, or you can actually turn off the stimulator. So when to consider DBS stimulation? I think some things to keep in mind are if medications have become less effective, if they're causing side effects, which are just not worth it, or if we can't push up side effects, or pardon me, push up the medicine because of the side effects we're incurring to a place where we actually would know if the medicines are a benefit or not, this would be a time to think about DBS. So the journey towards DBS is actually relatively organized and pretty linear. You would meet with a movement disorder specialist. You think about all of your kind of non-invasive interactions and interventions you can do first. And often while I'm doing this with someone who's had essential tremor for years, I will go on and kind of start the DBS surgery evaluation, which depending on where you might be, might consist of referrals to neuropsychologists to get a baseline of cognitive thinking and memory baseline, a physical therapy evaluation to actually score your tremor severity, and then a clearance with your primary care doctor or any other appropriate specialist before you meet the neurosurgeon. And then there is the lead implantation surgery and then the stimulator implantation. So the lead implantation surgery is usually the time where you will end up in the hospital overnight, since it is a brain surgery. And then usually people go home pretty quickly after that. The stimulator implantation is often a same-day surgery, since it's just the equivalent of a pacemaker installation, and then you go home. And then you'd meet the movement disorder specialist to turn on the stimulator and begin the programming journey. So here's just a few kind of a picture, if you will, of the whole system of both the kind of physician programmer, the patient programmer, and then the implanted units of your DBS system with Boston Scientific. So often patients ask, how do you know where to stimulate? And that is, I think, really where the technology of image guiding comes into play. And I think one thing to think about is that with your movement specialist, this has now become a lifelong relationship, and it is a marathon and not a sprint. So we are optimizing your stimulation throughout the remainder of your therapeutic course with your doctor. We do the first initial programming visit, and often the first 3 visits are really kind of the tweaking of the nuts and bolts of things. And then, of course, as your disease progresses, we continue to adjust as needed and think about, all of the various parameters we have to further optimize your stimulation. So as I mentioned earlier, the surgical target for essential tremor is the VIM nucleus, or the ventral intermediate nucleus. This is a region in the brain that can help restore some control to your movements. It's quite small, and we actually are trying to just stimulate a certain portion of the structure. And so that's where image-guided programming is really helpful, because we can in real time see where the electrode is in relationship to our target and neighboring structures, which you'll see a little bit more about. And I think we might even have a little video here. Let's see if this will play. So if you see this kind of, that colorful, that is the electrical field actually that you're seeing. We're also able to do something called directional stimulation, where we can direct the electrical stem in certain regions away from structures that might cause side effect when we're programming, and towards structure to optimize more control of tremor over time. And it's a really wonderful world to be in now that we can do this, and that we can even show this to you in real time when we're doing programming during our clinic visits. So because it's always great to have a bit of an analogy, we always say that kind of finding the sweet spot for optimization is like finding a treasure in a forest, your brain being the forest and that target being the treasure. So before, and how I was trained with DBS, we use imaging to know where the leads are placed. Yes, the neurosurgeons did this. As a neurologist, often I wouldn't be privy to seeing, besides on an MRI or a head CT, where the lead was. And so that helps if it's something really off course, right? Or like, oh, okay, this seems to be the right place. But everyone's brain is a little bit different. And we have atlases that give us an idea of what structures are where, but we are all kind of individualized humans. And so it can be a bit of a journey to make sure that accounting for where the lead is and then how someone's brain structures might be a little bit different, that we're in the right place. And as you can see, it was dark with no map before image guiding. So now with our image guided programming, it's actually a personalized map of your brain as the patient, which allows me to actually go, this is where this lead is. It's turned a little bit lateral. It's a little bit deep. It's a little bit to the left or to the right. And now I know how to tweak my stimulation based on this. And that is not just beneficial for the patient. It actually is really helpful for the physician because it allows us to be able to usually optimize your programming a little bit sooner than we maybe would have in the past. So, here is our map, right? And this is your brain. MRI is one way that we see it, and also the head CT. The treasure is that being superimposed actually on the interface of a physician programmer when we do our programming for you. So as you see, here is this lead, and here are the structures, and this is your VIM. And we have our neighboring structures. This is another nucleus in the thalamus called the VC, for example. And so now we know exactly where we're aiming. And so what I find now is that instead of having to do what we kind of call, we kind of have this initial review where we would go, here's our lead again, I'll show you the deepest contact, and we'd march all the way up the lead for every person, regardless of where the lead was. Now, if we have this visualization, let's say that the tip of this electrode was underneath, well, then we'd know, well, there's no point in going for this contact. Let's just go straight for these two in the center. And so seeing this location allows us then to get further, more efficient optimization of your stimulation. We also can see both with the imaging and with the patient that's with us. If we ask you, do you feel tingling or do you feel pins and needles or pulling? You can let me know that, and I can corroborate that with imaging and know then how to direct my stimulation based on that. So why programming matters. So we collect the imaging of your brain during the DBS procedure, and actually often before as a pre-op MRI, preoperative CAT scan. And then the images are collected and the mapping is done. And then that therapy that we are doing in real time when we program you is based on the mapping of your brain that we were able to collect. We are able then, with less sessions, to optimize your treatment plan. And really what that translates to is often shorter clinic visits, visits where we can then address the non-motor symptoms that you might also have, because we aren't just in the weeds of trying to find the sweet spot with your stimulation. It also means that it is a sooner time for you to actually start to notice benefit from your surgery and have improvement of your tremor, which is really the goal of why we're doing this. And another thing that I really love is the fact that we are now able to often avoid causing some of the adverse side effects that we get from stimulating neighboring structures, because we actually can see where we are and can direct our stimulation based on that to further, kind of make your situation and experience better. Overshot there, pardon me. So benefits to consider. Once again, reducing programming time, avoiding side effects, and the fact that it's personalized therapy. So there's one thing we know, we can know the textbook definitions of these conditions and what's supposed to work, but every person is different. Everyone responds to stimulation differently. Everyone responds to medications differently. So the fact that we can actually streamline to you as a person individually is, that is kind of the future of medicine, I feel. So a question we sometimes get, what if I'm already implanted with a different system? So even if you are implanted with a different system, we are able still to use your old imaging to be able to then also still come up with a map of where your leads might be. And then, of course, what would be usually replaced if you had, leads from another system is that you would then have a Boston battery. Okay. And I believe now here's just kind of an overview of the benefits, I think, of what we know to have with Boston Scientific and being able to program with them. This image-guided programming, which has really, really revolutionized my clinical practice, the opportunity for lots of stimulation options, which, I could go on and on about easily. The comfort of a battery, because of course, whenever you have something new in the chest wall, it can take some getting used to, but the fact that it's thin and contoured, round edges as opposed to sharp corners, things of that nature, it's a little bit easier for you to adjust to. The fact that the patient programmer has an MR section where if you're going to go for imaging, you can actually put it in MR mode if need be. And then for the rechargeable system, that you have a patient remote control and a charging system where you can have this little, shawl almost, and you can have your coffee or read the newspaper while you're charging at the end of the week. And then here are some further Boston Scientific resources. So if you have any questions, you can go to the website below.
All right. Thank you, Dr. Stone. We appreciate you taking the time today to talk with us and share some great information on DBS programming, and specifically the image-guided programming, which I think the patients would be very interested in. We hope everyone found this presentation really helpful today. Hopefully you learned something new. If you have any questions regarding essential tremor in general, we encourage you to visit the IETF website at essentialtremor.org, or you can call us toll-free at 888-387-3667. And finally, if you are a donor to the IETF, we want to say thank you for your support. If you aren't currently a donor, we hope you will consider a gift in the future to help us to continue the work that we do, promoting ET awareness, education, support, and research. So we're going to be hosting a variety of different virtual ET education events in the upcoming months, including webinars and podcasts. So look for notices on these events in our Tremogram e-newsletter, in our Tremor Talk magazine, and on our website. So thank you all again for joining us today. Thank you again, Dr. Stone. We appreciate your time and joining us today.
My pleasure. Thank you for having me.
Everyone have a great day. Thank you.